Dr. Kripa they will come on to present the case.
Good morning, everyone. I'll be presenting the clinics for today. Presenting Mr. A, a 65-year-old retired railway officer from West Bengal, who presented to us with chief complaints of weakness of both upper limbs for 12 months and weakness of both lower limbs for the last 10 months. History of present illness. Patient was apparently well till in his baseline state of health till July 2024, when he first noticed inability to button and unbutton his shirts with the medial two fingers of his left hand. He also noticed inability to open or close the bottle lids and had to use the other lateral three fingers to do the same. He also noticed difficulty in counting money and inability to roll food in his hands. He developed difficulty in holding the handle of his scooter and hence had to stop using it. Over the course of next 2 to 2.5 months, he noticed slippage of chapels, especially on the left feet, with preserved awareness of the same. During this time, he also noticed loss of muscle mass over his left upper limb and lower limb with progressive thinning. Over the next 1 month, he developed difficulty in raising his hands to his mouth while eating, lifting up his hand to comb his hair, and pour water over his head with a mug. He developed difficulty in washing his face and wringing his clothes. Subsequently, by October 2024, 4 months after the onset of symptoms, he noticed difficulty in climbing down stairs characterized by buckling of knees, and subsequently also developed difficulty in climbing upstairs. By December 2024, he developed difficulty in walking in uneven grounds. He was unable to lift his leg and navigate through obstacles. He predominantly became homebound. Over the last 3 months, he also developed difficulty in getting up from chair and taking small steps within the house. He also noticed spontaneous episodic twitching of muscles over the chest wall and both his limbs, each lasting for a few seconds. During the course of illness, the frequency of these twitches have increased. There is no tingling sensation of distal limbs, no numbness, no radiating pain. There is no breathlessness or difficulty in swallowing. There is no change in voice. There is no abnormal emotions, no history of difficulty in neck holding or difficulty in rolling in bed. No history of diurnal variation of symptoms, and there is no history of triggering of symptoms by exercise. He is able to perceive the hot and cold equally on both sides while taking bath. No shock-like sensations down the spine, no band-like sensations on the trunk. There is no history of unsteadiness while washing face, no history of any difficulty in walking in dark. He is a right-handed individual. There was no decreased responsiveness, emotional liability, or speech disturbances, no decreased smell, no blurring of vision, bumping into objects, no double vision, drooping of eyelids, or squint noticed by relatives or the patient. He was able to perceive hot and cold water and pain over his face, no decreased hearing, ringing sound in the ear. No difficulty in swallowing food, history of cough while eating, voice change or nasal regurgitation, no history in turning head side to side or shrugging of shoulders, no difficulty in articulating words, chewing food or protruding the tongue, and there is no difficulty in manipulating food in the mouth. He is able to perceive bladder fullness and able to initiate micturition as well. There is no history of dribbling of urine or incomplete evacuation, no history of erectile dysfunction, no history of bowel incontinence or constipation. There is history of CAM intake. There is no history of any skin rash, no history of fever, oral ulcers, or photosensitivity. Going on to the past history, he is a known diabetic mellitus type 2 for the last 8 years on regular medications, not on any insulin. Systemic hypertension for the last 8 years. Dyslipidemia for the last 8 years, all well controlled on medications. There is no history of any malignancy, HIV, or syphilis. Personal history, no history of ethanol or nicotine use, no history of any recreational drug abuse. Family history, there is no similar history in the family, born out of a non-consanguineous marriage, has 4 siblings and 2 children, all of them doing well. Treatment history, for the above symptoms, he consulted multiple hospitals where he was told to have spine-related issues and managed conservatively. In August 2024, he consulted a neurophysician in Chennai where he was diagnosed as diabetic peripheral neuropathy and was advised to continue with the physiotherapy exercises. However, there was progressive weakness prompting him to come to CMC. Summarizing the history, Mr. A, a 65-year-old gentleman, presented with asymmetric weakness of all 4 limbs, left more than right, insidious in onset and progressive in nature, distal more than proximal with wasting and fasciculation, no dysarthria, dysphagia or nasal regurgitation, no emotional liability, no sensory symptoms, no gallbladder involvement, and no family history. With this history, I would like to.
Okay. So how do you want to, approach this patient? What would be your approach?
So we are primarily looking at a patient who's presented with weakness of all four limbs,
Motor weakness.
of all four limbs, and it's a long-standing thing. It's been there for almost 12 months now, and it's progressively worsening. Along with that, there is no sensory symptoms that he's complaining of, and relatively intact gallbladder habits also. So this looks like a pure motor syndrome that is there with no gallbladder, no sensory component. Along with that, higher mental functions, emotional liability, all of them are also preserved.
So what would be your approach to find out where the problem is?
So if we come to a higher mental function, cortical sensations, they are
Yeah.
So we can either divide it as a UMN versus LMN way of finding.
So anybody with motor weakness, that's the way to approach it, LMN or UMN. So what are the differences between LMN weakness and UMN weakness?
So LMN weakness predominantly presents with significant weakness with wasting that is there, along with the tone is usually flaccid.
Let's go one by one. First one.
Weakness is
LMN it's got a lot of wasting.
Significant amount of wasting.
Will there be wasting in UMN?
Generally, no.
Long-standing.
Long-standing can.
But obviously not as marked and as prominent as LMN. Okay. Then so first is wasting. Then
wasting. Second thing would be the tone of the muscles that is there.
It's a tone element.
So in an LMN lesion, it's usually a flaccid. That is there. Usually UMN presents with spastic weakness.
Hypotonia.
Hypotonia.
Okay. Next.
If we look at fasciculations that the patient actually had, it's more of a LMN feature than a UMN lesion.
Okay.
Reflexes usually are brisk in a UMN lesion, whereas reflexes may be depressed or even absent in a LMN lesion.
Right. So based on the history, what does it suggest your patient?
Based on the history, it looks like a predominant LMN lesion because historically there is no UMN features.
So there is wasting, there's fasciculation, there is there's nothing to suggest hypertonia.
There is nothing to suggest.
What history would you ask to find out whether there's hypertonia?
There's en bloc. They complain. I mean, they're not able to move. When trying to move, they're able. It's an en bloc movement that they have, rather than each joint moving.
The limbs might feel tight.
Yeah.
They might, they might find difficulty walking. They might, drag the feet. What kind of somebody with a hemiplegia? What kind of what kind of gait will they get because of the hypertonia?
It's a spastic gait.
Yeah. So here there's nothing like that. And also the weakness seems to be more prominent in the distal muscles
more than proximal.
Started distal.
So
involved proximal. Okay. So there is wasting, there's fasciculations, there is no history suggestive of hypertonia. So suggests more like a element. Okay. So element, what's the next step in the approach?
So where in the element?
Yes. So what are the various possibilities, and your patient, how does it look? What does it look like?
So we can go from radicals. So if we look at radicals, predominantly they present with radicular pain that would be there. You can go to the plexus part of it. Plexus usually presents with sensory symptoms also that would be there. Then coming to the anterior console.
So how will the root involvement, what will it present like?
Root involvement would also have sensory symptoms along the root that is there. The dermatome or the supplied by the root will have sensory symptoms that are there.
And if it's localized, it's going to be just in that dermatome, you're going to have symptoms. Or let's say somebody has a disc disease, you might have shooting pain along that dermatome. So this seems to be a more systemic involvement, isn't it? Multiple level. Can the roots get involved in multiple levels?
Can at the cervical level, if you are looking at roots, can systemic illnesses can have like
the-
paraneoplastic syndromes can present with root
anything
involvement.
acute, the root involvement presents with the acute motor weakness, rapidly progressing over a few days to weeks.
GBS can also
Yeah,
present with
GBS can have rapidly, ascending weakness. You're not going to have sensory is not very
very
not predominant. Usually it's absent. So that is something which, but again, it's not going to start in upper limb distal. So it's not looking like that. What about plexus involvement? Can you think of a disease which causes plexus involvement, and what is it present like?
the plexus involvement, all these herpes simplex, like viral infections can have plexus also involved.
Have you managed anybody with viral involvement with plexus? Think of something which you managed. Fairly common disease, but this complication happen now and then. Usually the lower limbs. There may be pain, there may be wasting.
Disc diseases.
Diabetic amyotrophy.
Yes.
Yeah. So they present with uncontrolled sugars, lot of wasting, lot of pain in the lower limbs. So plexus involvement, asymmetric, but there is a lot of wasting. But usually it's lower limbs. Otherwise, you can any other disease, plexus. Sometimes you can have autoimmune involvement of plexus also, plexopathy. Other trauma could be there. But here there's no history of trauma, and it's the involvement. It's not sounding like it is plexus, and there's no pain, isn't it?
No pain.
There's absolutely no sensory involvement. So plexus, it doesn't look like plexus. What's the next one?
Plexus, then the nerve, anterior plexus, and then the anterior horn, and then the nerve neuropathy.
Okay, part. So we actually anterior horn cells. Anterior horn cells, element or element?
Element.
Element. So what will be the main feature of anterior horn involvement?
Significant wasting, but usually the power is distally, the power is better as compared to the wasting that usually the patient presents with.
It's element.
Element.
So you're going to have weakness, wasting, fasciculations, very prominent fasciculations. So that's going to be there. Usually, can it involve multiple levels?
It can involve. It can.
But sometimes, it can sort of, restrict it to one level, maybe just a cervical, but sometimes it's going to involve multiple levels. So what's the classical disease that causes anterior horn cell involvement?
Motor neuron diseases.
Motor neuron disease. Any other term for motor neuron disease?
It's called anterior horn cell disease also. Like
any other term?
The most common that we come across is the ALS, amyotrophic lateral sclerosis.
Correct. Yeah. So why is it called amyotrophic lateral sclerosis? Interesting term, isn't it? Amyotrophic, that you can understand. Amyotrophy.
The muscles are
wasting. Okay. Why is it called lateral sclerosis?
The pyramidal tract involvement.
Lateral corticospinal tract. Those days when they looked at it, they found that it looked sclerosed. So, and you have a mixed spectrum. Yeah. Some will have quite a lot of corticospinal tract involvement. Some will have more of anterior spinal involvement. Depends. Some will be more cervical. Some will be more diffuse. So that is something. But in this patient, if we is there an involvement of corticospinal tract historically?
Historically, there is significant muscle involvement.
Corticospinal tract.
Not historically, not very significant.
Dominantly element. And there is, at least in the history, there is not
much of human
features, isn't it? So that is makes you think, okay, is it really anterior horn cell, at least MND, whether it could be still, but we need more information, maybe some more information from examination. Okay, so anterior horn cell is a possibility here,
It's a possible.
strong possibility for the fact that there is involvement of so there's prominent fasciculations. Any other disease which causes anterior horn cell involvement? MND is a classical. You're going to see repeatedly, even for your exams.
Spinal muscular atrophy.
Spinal muscular atrophy is another one. And what would the history be like?
Usually it's lower limb more predominant, significant male predominance, and the progression is a little bit more slower. They have a better prognosis compared to MNDs.
Okay. Any other disease involving anterior horn cells? Not very common, or rather, is not seen in India now.
This not this history, but if the patient had bulbar symptoms, a progressive bulbar palsy would also have a predominant anterior
acute illness which can involve the anterior horn cells. It's not there in India now. We've managed to stop it. So poliomyelitis involves the anterior horn cells. So all those post-polio residual paralysis we see is an outcome of damage to anterior horn cells done long time back. Thankfully, for vaccine, we don't have it now. Okay, so we covered plexus. What's the next one? What about peripheral nerves?
Peripheral nerves predominantly would have a glove and stocking pattern of involvement, and also would involve some amount of sensory symptoms also.
Usually there is sensory if it's entirely a peripheral nerve, but you can have motor neuropathy also, isn't it?
Motor.
And how will the presentation be like in case of motor neuropathy?
There would be, it's a more distal to proximal, weakness that would be there.
Okay, right. And is it a possibility here?
Yes, we can still keep it as a.
You should still keep it as a as a differential. Then element. What else? Nerve.
Then muscle. We can neuromuscular junction.
Neuromuscular junction. What is the classic?
Usually they would myasthenia would be.
Does it sound like myasthenia historically?
There's no diurnal variation of the symptoms. No worsening with exercise. No.
Okay. Any other group of muscles which get typically involved?
Usually the smaller muscles like orbicular, it's those involvement that
extraocular
muscles that
ptosis. Nothing is there to suggest. So less likely. What about muscle?
Muscle, the myositis spectrum of it generally presents with pain that would be there. And
how long is this history?
Around 12 months.
12 months. So do you expect myositis to go for 12 months? You don't. So which muscle disease will go for 12 months or no?
Something like a muscular dystrophy spectrum of
myopathies. Muscular dystrophies will be even more longer, very long. Autoimmune myositis and all can go on for a long time. Can you tell me few muscle diseases which can classically involve proximal muscles?
All a muscular dystrophy spectrum of Beckett's, Duchenne muscular dystrophy, those can present.
How will the history be? How long the history by the time?
Actually, it's a childhood, adolescent onset and progressive.
Yeah, in a 65, we don't expect that.
Autoimmune myositis.
Like the two classical muscle involvement.
The polymyositis,
dermatomyositis. What will be the usual presentation?
There'll be severe pain that they present with, and there'll be skin lesions. There'll be other autoimmune markers
that will be there. I don't think pain is a common feature. It's mainly a proximal muscle weakness. Okay. So dermatomyositis, you also get skin involvement, but it's proximal muscle weakness. So it'll be typically unable to lift the hands, unable to stand up from squatting, mainly proximal muscle one. It doesn't look like this. There's a subset of diseases which can involve distal muscles also. But this again, you can't explain fasciculations and those kind of stuff. So what does it look like from history based on in the element spectrum, if you were to place your
anterior horn cell and nerve is also still a possibility.
Okay, right. So if it's anterior horn cell, what other history would you ask?
There is wasting, there is the fasciculations that is there.
Can there be secondary causes apart from?
Yes,
Mm.
usually, I mean, secondary causes like endocrine causes, some hyperthyroidism, hyperparathyroidism is known to cause
Paraneoplastic.
neoplastic.
So did you ask the history of loss of weight, loss of appetite, anything to suggest?
Significant loss of weight, loss of
Anything to suggest a malignancy anywhere? No. Okay. All right. Any history of toxins?
So he's been a retired railway worker. There's no exposure as such, and even water. This at home is a purified water. There's no history of any bowel
Right.
water usage.
Okay. So based on history, at the end of it, what? Okay. I think I'll ask Dr. Aditya Nair to add his, his comments and some questions. Dr. Aditya, are you there?
Yeah. Thanks, Dr. Ronald. I think Dr. Ronald has already covered most of the questions that I wanted to ask. I think nerve still remains a significant possibility here because at the end of the day, it's still an asymmetric quadriparesis with wrist drop and all as a presentation in a gentleman who's had significant CAM intake. Is there any other differences that you'd like to keep if you're putting the localization in a motor predominant neuropathy coming as wrist drop in both the hands in an elderly man? Any other possibility you would like to keep?
Toxin lead induced toxins.
Yes, so that is one which is unlike the other heavy metal intake which comes as sensory motor or sensory dominant. That is one which comes as a chronic neuropathy, can start as distal weakness in the hands. This is a disease which started in the hands and then gone to the legs. So that is unlike the typical neuropathy which starts in the lower limbs and then goes on to the upper limbs. So I think that nerve should also be considered in the differential among the treatable differentials because for an ALS we generally want a UMN and an LMN either in the examination or in the history. Here, because everything seems to be still element dominant, nerve is definitely a possibility that we would be. Thank you.
Okay. All right. So let's go to your examination findings.
So my localization based on history was asymmetrical weakness with significant wasting and fasciculation, localized to anterior hornsel, element predominant. Examination, the patient was alert, conscious, oriented to time, place, and person, and was not in any apparent distress. Vitally, pulse at 84 beats per minute, regular, normal character, volume, no radial or radiofemoral delay. Blood pressure was 126/84, respiratory rate at 16 per minute, temperature 98 degree Fahrenheit. There was no pallor icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Systemic examination, no cataract, frontal baldness, acid phases, hypertelorism, clinodactyly, no contractures. Fasciculations were present, no hyperpigmentation of skin, tongue hypertrophy, no Cushingoid habitus, no skin rash, no calf muscle hypertrophy, no low-lying posterior hairline. Higher mental function, patient is right-handed, normal intelligence, comprehension and orientation. Memory, immediate, recent and remote memories intact. Speech, comprehension, fluency, repetition, naming, reading were good, no emotional liability. Cranial nerve examination, first cranial nerve was not tested. Second, visual activity for both near and far is normal in both the eyes. Color vision is normal bilaterally. Visual fields normal. Pupillary reflex is present bilaterally. RAPD not present bilaterally. Fundus was normal on examination. 3, 4, and 6, there was no ptosis. Extraocular movements were full. Pursuits and saccades were normal. Fifth cranial nerve, motor, there is no weakness. There is normal power of the muscles of mastication and temporalis. Sensory, normal in V1, V2, and V3. Corneal reflex is present bilaterally. Conjunctival reflex is present bilaterally. Jaw jerk was present, not exaggerated. Seventh cranial nerve, motor function, no loss of nasolabial folds bilaterally. Wrinkling of forehead is present, and taste sensation is present in the anterior 2/3 of tongue. Release is air conduction more than bone conduction, and there was no lateralization. Vestibular function was also normal. Cranial nerve examination, uvula was central, gag was present bilaterally. 11th cranial nerve, turning of head sideways was normal, shrugging of shoulders bilaterally was weak. 12th cranial nerve, there's no wasting of fasciculations of the tongue. Protrusion of the tongue, there was no deviation to any side. Power and tone was normal. Motor system on inspection, the patient was examined in supine sitting and standing position. In the supine position, the patient was in neutral position. There was significant wasting of the paraspinal neck muscles, pectorals, thenar eminence and hypothenar eminence, hip adductors, hamstrings and tibialis anterior. And there was significant fasciculations that are present. This is the wasting of all the small muscles of the hand, thenar, hypothenar eminence and the pectoralis. These are the fasciculations that were observed during the examination. Motor examination, arm bulk was 21 bilaterally, forearm 17 bilaterally, thighs 27 bilaterally, calf 22 centimeters on the right side and 21 on the left. Tone on the upper limbs and lower limbs bilaterally was decreased. Motor power examination, neck flexors were 5 by 5, extensors 5 by 5, shoulder abduction was 4 by 5, adduction 4 by 5, flexion 4 by 5, extension, internal rotation and external rotation all 4 by 5. Elbow flexors 3 by 5 and extensors 3 by 5, wrist flexors 3 by 5, extension 3 by 5 and extensors of the finger were also 3 by 5. Intrinsic muscles of the hand, palmar introshair, dorsal introshair and lumbricals all 3 by 5, adductor pollicis 3 by 5 bilaterally, thenar and hypothenar 3 by 5, hand grip was poor around 70% bilaterally. Coming to lower limbs, flexors bilaterally 4 by 5, extensors 4 by 5, abduction and adduction 4 by 5, knee flexion at 3 by 5 and extension at 3 by 5, ankle dorsiflexion and plantar flexion at 3 by 5. The subtalar joint inversion and eversion was 2 by 5. Intrinsic muscles of the foot, adduction and abduction 1 by 5. Sensory symptoms, fine touch, pain, temperature, vibration sense and joint position sense was intact bilaterally. Reflexes, all the reflexes on the right and left biceps, triceps, pectorals, brachioradialis, knee and ankle was brisk bilaterally. Superficial reflexes, abdominal reflex was present and plantars were bilaterally flexors. There was cerebellar examination, there was no nystagmus, no intentional tremors, no scanning, no defibrillation. Upper limb finger nose test was bilaterally normal, there was no dyskinesia. Lower limb heel shin test was normal and tandem walking was able to walk. In the spine, there was no deformities, no tenderness, meningeal signs, no neck stiffness, Kernick signs and persistencies were negative. Other systemic examination, CVS, normal S1, S2, heart sounds out, there were no murmurs. Bilaterally, respiratory system, vesicular breath sounds, no added sounds. Per abdomen, soft and non-tender, there was no hepatomegaly or splenomegaly or free fluid. Summary is 65-year-old male with progressive weakness of all four limbs, distal more than proximal with wasting and fasciculation. Examination confirms the distal more than proximal weakness with asymmetric wasting, fasciculation and hypotonia with exaggerated deep tendon reflexes.
Okay, so anything new you've got from the examination?
The tone of the muscle, which was not very clear with the history, there is significant hypotonia that is there. Along with that, there's exaggerated deep tendon reflexes.
What was what was the reflexes? What
in all the four limbs,
everything is brisk.
Is actually
no clonus.
No clonus.
Okay. So, what does it tell you? The fact that reflexes are brisk.
That's the UMN component.
Pointed toward there may be a
UMN
involvement, even though the tone is
hypotonic.
Entirely hypo. Right. And there's while checking tone also it's fully hypotonic. There's not even a little bit feature of
even the plantar clasp and all that. There's no catch, none of it is.
And how long is it symptomatic? 1 year, isn't it?
Yeah, onset of symptom is 12 months, but worsened over the last 6 months.
And sensory is entirely normal.
Entirely normal.
Okay. And right. And what about the bulbar involvement? There is
no bulbar involvement. There's no historically, there's no regurgitation of food. There is no change in voice. Examination wise also gag.
Muscle involvement is there?
There's no neck muscle involvement.
Okay. So what is your, at the end of your examination, Would you revise your differential diagnosis, or is it the same?
So after the end of history, we had a predominant LMN only lesion that we were looking at. So hence the differentials we had thought of was anterior hornsel and nerve was the other differential we had thought of. But examination wise, this looks like both UMN and LMN involvement. So anterior hornsel involvement with a UMN component looks more likely. And MND, which was a differential we had considered, is kind of confirmed with it.
More likely.
More likely.
Okay. Right. And he's got, he's got history and examination wise, he's got nothing to suggest any other malignancy or other autoimmune disease, nothing.
Historically, nothing. Examination wise, also there are no nodes anywhere. There is no organomegaly.
Is he a smoker or an alcohol
Not a
consumer?
not a smoker.
Okay. Can I ask? Aditya, have you got any any comments or questions to Kripa?
Yeah, just one thing. Among the differential, is there any possibility, like, because the symptoms start in the upper limb, and you're having like element findings in the upper and in the upper limb predominantly as the onset of symptoms? Suppose I give you a different scenario where you have some upper limb which is element and the lower limb is spastic, and all the findings are below the neck. Is there any other differential that you will consider in a 65-year-old elderly man who can present with similar findings, but something which is treatable? Quite common.
Cervical myelopathy would explain an upper limb.
Go ahead.
Yeah.
So cervical.
Can you have a mixture of UMN and LMN findings in a patient who has a cervical spondylotic myelopathy, which is quite common in the elderly? Will you have a mixture of LMN and UMN findings in such patients?
So any cervical cord lesions are foramen magnum. So high cervical lesions would be a differential for this. Along with that, secondary causes like paraneoplastic autoimmune also needs to be ruled out.
Let's say he's also got sensory involvement in his upper limbs. He's got some ulcers, in some tropic ulcers. Everything fine cord cervical.
Syringomyelia can present.
I'm not sure whether Dr. Aditya. Aditya?
Yes. Please carry on. Yes, syringe is definitely a differential, except that we are not getting the reflexes. But I think in elderly people, the reason why we evaluate them, especially when the bulbar is paired and the onset is in the upper limb, I think spondylotic myelopathies are always a differential. Here, the only reason is that multiple levels of element are involved. So you need to have multiple segments involved, and we can't here even the lower limb, according to the examination, the tone is element hypotonia, which would not be the case if you had a cervical spondylotic myelopathy. You would be expecting like a spasticity in the lower limb. So we're not getting that. So that seems to be less likely. But in a scenario where the lower limbs are more spastic and upper limbs are having a mixture of UMN and LMN, I think spondylotic myelopathies need to be case for, especially in a patient who does not have bulbar dysfunction. The spondylotic myelopathies can be relatively slow growing. They may not present with bladder and those kind of symptoms. So something worth checking for.
So he has no increased tone, isn't it?
Increased tone at all.
The only pointer of a human is
the reflexes.
And it is a pointer, It is a feature of human disease. So he's got predominantly element, but also has human features. So I would go with what you're saying. I think first likelihood, most likely MND, because it's got mainly element plus human. But we need to rule out the other, other possibilities, because it's going to be a sort of a diagnosis where we're going to say not many options are there. So okay. So how would you evaluate this patient?
So my diagnosis after the end of history and examination, its anatomical localization is an element plus UMN. Pathology looks like a progressive degenerative disease of the CNS. Most probably a motor neuron disease, probable amyotrophic lateral sclerosis. So the investigations I would do were with respect to the differentials we had thought of. So I'd like to do a CBC, TSH, calcium phosphate, vitamin D, ECG and an echo. Along with that, I would need an EMG, NCS with CSF analysis and cross-sectional imaging.
Why would you do a ECG and echo?
ECG and echo because we are thinking of things like hyperthyrotoxicosis with hyperphosphatemia, like those can have secondary ECG echo findings.
Okay. Yeah. Okay. So EMG and nerve conduction studies you want to do?
EMG and nerve conduction studies because they'll classically motor neuron disease presents with a lot of fibrillation that's due to the repeated denervation that happens, and there are large motor complexes that can be there. So
if it is normal, let's say, if it's not showing, would your diagnosis change?
Clinically, my diagnosis would still be a motor neuron disease.
Okay. And how would your CSF analysis help?
This is to rule out any secondary things like malignancy and autoimmune things. So motor neuron disease classically presents with a normal CSF. There can be a mildly elevated protein levels, but usually the CSF findings are normal. Cross-sectional imaging also to rule out any occult malignancy we are missing.
Okay.
Also like to do a spine
Cross-sectional
screening.
imaging of chest and abdomen.
Chest, abdomen.
So you want to look for secondary causes.
Yes.
Okay, that's understandable. I'm not sure whether CSF would add really any value. I'll ask Aditya to comment on that. What other tests? Do you have another slide on investigations?
No, it's just the EMG findings.
Okay, sure. Okay, so Aditya, you think CSF would add anything to?
I think it depends on in this current patient. We would probably do it because the presentation is like given in the picture that she's shown. It's like a finger drop and a motor dominant element syndrome with multiple segments involved. So for us, the treatable differential would be a multifocal MMN, multifocal motor neuropathy. So CSF would be primarily to see if there's anything reversible, probably even ganglioside antibodies in the autoimmune screen from the matter. But I take the point that despite this amount of wasting and fasciculations, that the reflexes are brisk. That is a point well taken. But from the point of view of management, probably we will always try to chase for treatable causes in this setting.
Okay, sure. Okay, what did the EMG show?
So actually, the EMG showed a increased latency and the amplitudes were reduced. The amplitudes of the waves were reduced, and despite multiple stimulation, there was no stimulation of the nerves, distal nerves in the medial and peroneal nerves. Basically, it showed a denervation process with multiple fibrillations.
Okay. Any other test you have?
No.
Was the imaging of the C-spine done?
Imaging of the C-spine was also done. Final reports were awaited, but verbally reported as normal. There was a PET CT also done, which was also verbally reported as normal.
Okay. So the EMG is also looking like it is MND. Okay. So how do you manage this patient?
Once we have a disease diagnosis of MND, first thing is about patient and relative education because it's a progressive degenerative disease. We're looking at an ALS that's diagnosed. We're looking at lifespans that are up to 3 to 6 years is what usually they have respiratory paralysis within that time. So rehabilitation along with education about the disease and the progression. If the patient develops bulbar weakness, to immediately start on respiratory rehabilitation. So initially it's with NIV. Subsequently, patient goes into an intubated state. Along with that, there are experimental drugs that have been used. Relozole is one of the drugs and edaveron is the other drug. But they've not known to significantly decrease the progression of the disease. In a LMN predominant MND, there is some evidence of steroid, IV steroids also.
Okay. So it's going to be mainly supportive management. There is very little help, with the drugs. I think Riluzole increases lifespan by a few months. I think it's less than 6 months. There used to be a program given by Sun Pharma used to give free. Is it still there?
Yes, Your Honor, it's still
Okay.
there.
And what's the other drug you said?
Edaveron that's given
Okay.
every all.
I'm not sure about how it helps in terms of increasing survival. Dr. Aditya?
Yeah, it's a free radical scavenger. Again, most of the trials in ALS are discussed based on the ALS FRS score, that is the ALS functional rating score. So the average decline per month is 1 point every month, so they lose 12 points in a year. So Riluzole gives them a retardation by around 0.8 points, while Edaravone by around 1 point. So all of these, this is an intravenous therapy, the Edaravone injection. So sometimes it will be cumbersome for patients, especially if they are progressing, difficult to take them to hospitals for getting an IV line and getting the injections done. Riluzole being a tablet is much more uh, easier for the patients
to take, yeah, but sadly it doesn't, it has no major effect. So even if you don't give it to some patient, I think it's okay, but supported treatment is what is really important. I think in the Western countries, the supported treatment is so good that some patients manage to live for a long time. Do you know anyone who's lived for a long time? Yeah, Stephen Hawking is managed with all these gadgets for much longer. Things like preventing aspiration, suction devices, and lots of things which is being done mainly by the occupational therapists, which they help the patient. Um, yeah, so that's something. If the supportive systems are very good, patient can be well managed. But I'm not sure how patients whom we see will be able to manage. The outcome is not going to be very good. In terms of MND, can it involve involve cortical functions? Any
So there is
dementia that can.
So frontotemporal dementia is known. I mean, it's MND with a variant. It's a variant of MND with frontotemporal dementia.
Yeah.
And also the pseudobulbar symptoms also involve the emotional liability, that part of it also.
Yeah. Okay. So that is something to be kept in mind. Yeah, I think I don't have any other questions. I think you did a very good history and very good examination finding. Thank you for those pictures also. I think it was a good, overall it was a nice discussion. I think it's an interesting case. The fact that just risk reflexes alone, nothing else to suggest human. A lot of nice findings. Any comments from Aditya before we close? What's the time? Yeah.
Thank you for giving me the opportunity to participate in this. I think it's been learning experience for me also. Yes, the case was a little challenging for us because it's a very clear-cut upper motor neuron findings, and it's quite easy. In element dominant illness, we are always looking for differential diagnosis. The need in these kind of patients, we are even needing the patient, especially when you have asymmetric hand weakness and leg weakness. Among the muscle diseases, intrusion body myositis is also something which comes asymmetrically, can involve the distal and intermediate finger flexors and all. It's in fact a close mimic of ALS. So element dominant syndromes are much more differentials, and we tend to look at them a little more closely than the upper motor neuron involvement, especially if the bulbar is not involved. If the bulbar is involved, the differentials come down, generally likely to be ALS and will progress. So as a neurologist, we try to see for differential possibilities. And so ALS is progressive, it's a progressive disorder. So in these kind of cases, we tend to ask them to review and see if they're clinically progressing or has there been some stability with some intercurrent treatment that they've given. So sometimes we've had some cases where we thought it was ALS, but sometimes they've shown improvement also with some intercurrent immunotherapy. So premature closure also sometimes should be careful in certain types of variants which come there. That's all from my side. Thank you.
In terms of supportive management, is there anything new available, Dr. Aditya?
Yeah, so drugs, I think supportive management wise, I mean, in our setting, what we try to do is depends on at the site of onset of the disease. If it's a bulbar onset of disease, then and if it's an element dominant with lots of regurgitation and all that, then we counsel the patient early on peg feeds because nutrition is something which can improve mortality, survival benefits, and bulbar also tends to go to the neck muscles, and they go on to non-invasive kind of ventilation requirement earlier. So when the bulbar starts, we actually start looking closely for is there any evidence of a chronic type 2 which requires them to have at least maybe a nocturnal BiPAP or something. For a limb onset, the upper motor neuron types of ALS tend to actually progress slower. We can, more rehab opportunities are there. Element dominant ones tend to progress faster and tend to go into the bed faster. So those possibilities are less. But early PEG initiation and respiratory like BiPAP kind of adjustment actually can improve the quality of life, apart from the therapies that you've already mentioned.
Sure. So thank you, Dr. Aditya. Any comments from the other doctors who have joined us online? Anybody in the audience here wants to add anything? Okay, I think no one has questions. I really want to thank Dr. Kripa for doing a fabulous presentation, and also thank you, Dr. Aditya, for joining us in this API clinics. And I want to close by thanking all of you who have who found the time to come and join the clinics. And we will do we have a clinic next week also? Yeah. Okay. So we will meet next week, next Tuesday, same time, 1:30. Thank you so much.